Okay, initially when I heard about Lunchbox, I thought it would be in a small room with some residents. So the presentation is mostly a resident-based presentation. Just some thoughts. So how is my approach on rotator cuff repair? So if you're a proficient surgeon and quite experienced, you may walk out now. Okay, so let's go.
It's always a pleasure to hear you.
Yes.
It's always a pleasure to hear you.
I will try to entertain you for another 10 minutes.
Okay.
Welcome. Thank you. Which is my approach when I'm dealing with a patient with a rotator cuff repair. You can see some photographs. This is a patient I pulled out. I've operated on her yesterday morning, actually, before coming here. And you can see she has a full thickness tear. She has a full thickness tear, and with a good, let's say, quality. It is a chronic tear. However, she did mention an injury about 4 or 5 months ago. She was around 69, 70 years. My approach is I spend a lot of time cleaning up the bursa, cleaning up everything, synovitis. Most of my time is cleaning up the shoulder than fixing the cuff, because with all the new instrumentation we have in the anchors and our techniques have improved, to put down and fix a cuff is a fairly easy job. The most difficult is to clean up and try orientate yourself and understand actually what is the pattern of the cuff tear. So when we clean up, we have this kind of picture, and very important is to prepare the greater tuberosity bed where we're gonna put the cuff on in order to heal. We want the biologists. We can use a rasp after the radiofrequency or even the burr. But not too much if we're going to place anchors there. We have to have this in mind. And also we have to change portals, not postals. Change portals in order to have a better view of your tendon tear, to understand the 3D anatomy, because this is the most important aspect of how you're going to fix your tendon. If you understand the 3D anatomy of your calf, it's something dynamic. Okay, you have an idea from your MRI scan, but it is dynamic. You have to understand it then. And then you take a grasper and you pull, and you try to find out which way you have to pull in order to reduce the tear. In this tear, when I was pulling the back, it was not coming, nothing was coming forward. When I pulled the front part of this small U-shaped tear, as you can see here, the whole thing started reducing. Okay, so now more or less I've done my decision. We're gonna use a side-to-side repair, some more rasping and preparing of the bed. So I'm gonna use a side-to-side and fix it lateral with one anchor. It's very important to assess the tendon quality. Okay, depending on the tendon quality, it depends on the number of the anchors, patient's requirement, and also the cost, because a double row repair, it's an increase, at least for Greece, the patient has to pay for the anchors in the private sector at least, which is a factor as well. So this is this patient. Those videos are a bit unedited. We're using the fast pass in order to pass the anterior part of the side to side. And then I've used one of those rhinos. And if we put the sutures in the correct place, suddenly the tear will start reducing in size and shape. And here, with the side to side, a bit more rimming, you can see after doing a knot, we are closing down the cuff tear. So we have a better situation now, and we have plenty of tissue in the correct place in order to fix it distally. And for fixing it distally, the last couple of years I'm using the RC instrumentation. The fiber, I find the tape much more, you get much more better grip with the tape on a tendon than with sutures. And that allows you with smaller with less tapes to use and get a very good result. In the previous situation, you would use more sutures. And if you decide where you're going to put your anchor, sometimes even with one anchor, if you decide to go with a minimal approach, you can close the tear. See, once you pass your fiber tapes, you test which is the best way to reduce it, and which is because the place where you're going to put the anchor is going to pull the tendon. So if you're going to have the best reduction, it's important to have the anchor in the correct place. Here you see we use a punch. I've decided on my position. Okay. And here you can see just the technique. You pull the tapes, you reduce the tendon, and then you fix it solidly with your anchor. This is a 5.5 Swivelock. I prefer larger anchors in these patients because that allows me to use less of them. And also we have the, okay, here you can see there's a bit of a loop of a gap there. So you can either use a suture of your anchor to bring it down, okay, just a bit of a dog ear, and you can do that in this way, or you can put a second anchor if you want to do it differently. However, if you try to be as much as minimal, just the suture I think should be enough. And here is a final result. You pull a suture through, you tighten it, and that's reducing. That's reduced the tendon well, and with one side-to-side suture and one extra suture and one tape, everything has closed down nicely. I more or less always tend to do a subacromial decompression in all my calf tears. I've never regretted that, and the only time I regretted was when I didn't do it. So some decompression, I think it's always helpful. And this is another case, which here is a greater tuberosity fracture. And as you've seen, I've used a double row repair with speed bridge because in this situation, we want the maximal fixation, okay? So again, very important to clean up, to locate the fragment and reduce it. This video, you can see just how it looks like. This is a fragment and very good quality tendon into a young patient, okay? And you can use a speed bridge technique with 4 anchors to repair this tendon. And you can see this is a final result, very solid fixation. I did some minimal decompression this guy as well, in order to not to have problems in the future. And you see you can have a solid fixation here that allows us to mobilize it with the physiotherapist after 3 weeks. Thank you very much.
Thank you, Christos. Do you have any question for Christos Sinopidis or for Apostolos Gantios for the first talk? So, Christos, you prefer this technique, or it was this TR that you want to show us?
I mean, this is a spectrum of the 2 techniques I use. I use single row technique. I try to be minimal, but also I can use double row technique. And I'm using this kind of Arthrex anchors the last 2 years. Because I find it's quite good fixation, and I like the tape quite a lot. You can feel different when you're holding your calf on a tape than holding it on a suture only. As I said before, there are factors. If you have a younger patient, you know you're going to load it a lot. You want to go for early mobilization, you've got high activity, then you try to do some double row repair or a combination. But I think most of the population, at least I am dealing with sort of degenerate rotator cuff tears, you fix them well, and you just start the mobilization a bit later on, and they're doing well. You have very good results.
And they are pretty reliable anchor, pretty easy to implant it.
As I said, everything becomes easy once you have cleaned well and debride everything, and you stop the bleeding, and you have a good view. From that point of view, yes, it does make things easier for you, this kind of instrumentation. Yeah.
And give you a second chance with and gives you a second chance with the extra suture.
Well, you have an extra suture in every anchor if you want to use it. But again, even with these anchors, you have to get used to them, you see.
Of course.
Because if you start pulling too much or whatever, things. We're looking at osteoporotic bone. But that's why I'm using the 5.5s. I find them much more solid.
Good tools are much more useful in the hands of an experienced surgeon.
Thank you.
So, if you don't have some to discuss, I would like to thank Arthrex for this lunch symposium, and we can proceed with the rest of the program.